again. Uh, so today we are going to learn about management of pain part 1. Last week we learned about uh, pain and pain types of pain, assessment of pain, and total pain concept. That all things uh, we learned already. So today Dr. Aravind will be taking management part 1. So that is mainly NSAID and adjuvants. So Dr. Aravind was our last week faculty. We all know him, who is working as a palliative care physician since last month here at Pallium India. Dr. Aravind, welcome back and over to you.
Am I audible?
Yes, you are.
Yeah. And thank you, Shivaji, for again a wonderful introduction. Well, in the last class, we actually studied what pain is and derivation of pain and understanding what pain is. So today in this class, we'll be actually thinking of we have understood what pain is, but we need to understand how to manage it, how to understand what pain is, and how to take away that so-called pain or so-called misery from a patient who is actually going through that subcutaneous ordeal. So this is the main thing that we are going to discuss today, that how to manage pain. And as per the management, we have a course of understanding what is pain classified as, how is being pain classified and taken over by various other institutes that have, understanding pain and how to manage it. So first, as per most, according to the international human rights, the countries have actually provided pain treatment and management and medications as part of their core obligations. That is under the right to health system. That is, everybody has an equal right. In India, we have actually studied that everybody has a right to speak, a right to show their freedom, press freedom, and these kinds of freedom actually have interest, the right to health. And in that, a subdivision has actually been made like a right to have a pain-free life. And this is actually in accordance to every international human rights law. So you need to be out of pain. So pain treatment medication should be a mandatory cost for everybody in every hospital, every institution, in every way. And failure to take responsible steps to ensure that people who suffer pain have access to adequate pain treatment may result in violation of this obligation and deemed as cruel, inhuman, and degrading treatments. And cancer pain is now a health priority, and WHO, which is actually the World Health Organization, has developed policies and strategies to treat with an emphasis of total pain management. So total pain management has to be taken up as an immediate and a very effective cause for reducing the burden of each and every patient that we usually see in our settings. So what WHO has actually done is that it has taken up pain and it has made some valuable reasons and valuable strategies in according and dealing with the pain. What WHO did is, it actually made a thing which is called the WHO analgesic ladder, where it has been teaching for every medical professional on how to use. We know that there are a lot of analgesics, from starting from a basic paracetamol. We are talking about so much big higher analgesics, which is actually being used as like in opioids, which we actually use morphine, fentanyl, and these kinds of most of the opioid and the other adjuvants that we use are being titrated in various sources and as per the need of the patient. And if it is made like a ladder, as you have seen in this photo, the actual thing is you can actually see that how much have to be increased and how much has to be titrated in order to get the desired effect. So pain has to be abolished in one or the other way. And in this, we'll be studying how to approach in such a situation and how to reduce the pain as per the patient's requirements. So going up next. This is actually the WHO pain relief ladder, which is being the exact same photo that the WHO has been published, and in which it is showing as a step pattern approach, where it is looking like a step 1, a step 2, and has a step 3. Today, mostly we'll be dealing with a step 1 strategy, how we'll be dealing with it, which is related upon the non-opioid stagings. Non-opioid things where actually we are using only with adjuvants and a non-opioid analgesic, which actually has paracetamol, NSAIDs, and usually adjuvants in it. So can anybody say what adjuvant is? Like, you can see in every step we have written a non-opioid and an adjuvant, which itself signifies that opioid, non-opioid, and an adjuvant is being used in each and every step, right? So can anybody tell like what an adjuvant is? Can anyone have an idea of what an adjuvant is? Yes, Hema has written some examples are antidepressants, anticonvulsants. Yes, yes. So what is basically actually the work of these adjuvants are? You have a building standing and you have some pillars. These pillars are the things which are actually making the whole structure stand up, right? And these pillars, each and every pillar has a role because if one pillar just breaks down, whole of the structure will be in an infinite chaos. It may fall down from any level and it may have its own things. So what is these adjuvants doing? If you give 100 of some analgesic, you need to just add some of an adjuvant, like 50 of the particular adjuvant, so that this 100 thing just comes down to 50. So that 50 of this and 50 of this adjuvant can help together to achieve that 100 pain. So this numerical system, I just for an example, but we'll go according to it so that you can understand like where an adjuvant can help for a non-opioid or even an opioid. For even an opioid, it can help for a very much good distance. So we'll be talking about step one today, where the patient comes to you with pain and you can give him a known opioid with or without an adjuvant. You can just start from a simple basic analgesic and then you can move on further with other adjuvants which can actually help with the known opioid drug that you have been used. So this is the basic thing. So this is the basic thing of how you have to go with the WHO ladder in understanding and treating pain. So one is by the mouth. That how do you give by the mouth? Every drug that you usually see in and around palliative medicine, these can be given by mouth. Can you just give me one good reason why like all the medicines can be given by mouth? I'm seeing very less activity today. Like everybody's so sleepy or what happened? Can anybody give an just give me us one pointer or just say one line which you think that why like all the drugs are usually mouth friendly. It can be given per oral in case of analgesics and in case of cancer pain. Anything related to pain, you can give it per oral and it has a very good bioavailability and it can be given for the patient. And why do you think oral is the best thing for these patients? Anyone? Yes, Josna. Yeah, you're right. It is, yes, it is, you don't need any medical practitioner or personal to administer it. Yes, Jyoti, you're also right. It is painless. So the most important thing is that all the people who are in pain, they can't be under your surveillance like 24 into 7 and then you can give them or administer like IV doses or subcutaneous doses or any other doses. While for a painless or yes, less pain, yes, Vinisha, you're also right. No need for any assistance of how to take Jyoti, you're also right. So like the reason is this, that you can give it to anybody who can actually go to their home in their own settings. The palliative itself is dependent upon that, right? You be with your people, you be with persons you love, you be in an environment which is friendly to you. So in that particular environment, you don't want to have that stress or you don't have to go through that pain of taking in the medicine. So oral is the best way to take a medicine, and then this is the reason why like every opioid that we have known is being titrated in a way that it can be used by mouth. You can use it and then you will feel pain relief. So this is the one thing.
This is the one thing. Very.
Okay, sorry for that. So next is you should give it by the mouth, and next is by the ladder. By the ladder, which means that we have the last thing that we have seen. It is as per the ladder, the pain. Any person coming to you with, you can't just start him on. Somebody's coming to you with just a pain score of that. We have learned about the pain scores yesterday. And if you have a pain score of around like 3 or 2 or something like that, you can't just directly give a morphine and okay, this is the pain that you are going to have. So I'm giving you morphine so that you have a painless, journey ahead. That's not the way how you have to approach a patient who is coming to you with pain. Because when he comes to you with pain, there is a particular amount of increasing doses or increasing strategies that have to be taken place. So first you will give only this much, and then you go up this much, and then you have to add on something to decrease the pain. So it is a stepwise pattern so that it will be much more useful. And also there is a lot of tendencies where patient can abuse opioid drugs and other things. So that is the reason why step one usually doesn't have any opioid drugs in it. It is only the non-opioid drugs. So by the ladder, it is like you start from the step one and according to the severity of the pain, and then you move up. And if the pain is very severe, you can directly go to step three also. So just because somebody said that, okay, if somebody comes with pain, I will go to step one. I will give him some NSAIDs or I will give him some paracetamol, and then I will see. Think of a patient who's coming with a cancerous growth, a big fungating wound over his, cheek, and then he comes with uttering pain. He's coming with a 10 on 10 pain. Will you give him paracetamol and send him away? Anyone? Just because somebody said that, okay, I'm going to give him, I will go with a stepwise approach of the WHO ladder, and then I will just give him paracetamol, and then I'm going to send him back home. How many of you think that that is right? That is ethical, that is humane? How many of you think that it is humane? How many of you think that it is humane? Somebody coming with so much of pain and you just give him a paracetamol and ask you to go back home. How many of you think? Okay, Prisha, what I meant is somebody is coming you with so much of pain. And in WHO ladder, it's said that if somebody is coming with pain, the first thing you have to do is that you have to go with a stepwise approach. You need to start with step one, and then you need to, if step one didn't work out, you need to go to step two, and if step two doesn't work out, you need to go to step three. So this is the escalation of analgesics, giving analgesics in a pattern which WHO recommends. WHO says that you have to go through this ladder, but it says one more thing: you need to see patients' pain also, right? So if someone comes to my OP saying that I have a pain, I have a big pain, a big ulcer over my cheek, and it is so painful, and I just give him paracetamol, and you just take it like for 3 times a day, and then if it doesn't affect you, if it doesn't relieve your pain, come back. If I say such a thing, do you agree or not? This is the thing what I'm saying. Yes, so you people are not agreeing to it. So this is the one thing that you need to understand. If somebody is coming to you with pain, you need to assess the pain first. This is the reason why my first class was upon assessment of pain. How will you assess it? How will you identify how much pain that patient is going through or that person is going through? So as by the mouth, it should be by the ladder, but understand that if the pain is very severe, you can even start with a step three, that you can directly start that patient on morphine. Nothing says that it is contraindicated that if a patient with a so much higher degree of pain need not go through step one or step two. We can directly take it up to step three. We can directly jump to step three if you have that much of pain. So this is one thing you need to use from your brains. It's the one thing. So the next will be by the clock. That is, a continuous pain needs around the clock analgesics according to the duration of action of the drug and not in a pain basis. A patient who is having a pain throughout the day, it has to be regularized as per the clock. That is, if I give a pain medication which acts for only 4 hours, you have to repeat that drug for every 4 hours. So that you have to write Q4th hourly, right? You have to give the drug 4th hourly so that the pain, there is no amount surpassing that. The pain is being increased just because the drug is decreased. This should not happen. Every time it should happen like the pain is always the same because the drug level, the drug concentration in your body is the same. So that pain doesn't overtake the drug capacity. So the drug capacity always has to be maintained. So by the clock, it should be given by the clock. Each every 4 or each every 6th hourly, the medication has to be given. And individualized to the patient. Like some patient who is coming to you with a big ulcer over the mouth and another patient who is coming with small ulcer on his little finger. These two are two different scenarios. These two are two different patients with One thing common, that is pain. But that pain will be different in different situations. You can't expect a person who's having a big ulcer over his chin having the same pain of a patient who's having an ulcer over his small finger. So this is very important. Individualized to the patient. You give the drug as per the requirement of the patient. So the right dose is the one which relieves the pain. So titrate the dose till the patient is saying that, okay, now I am relieved. I am relieved of my pain, and that dose is for that patient. It doesn't mean that another patient who is having the same big ulcer over his mouth, he might require more, opioids. He might require more, or he might even require less. So these things are pretty individualized. You can't say that a patient who's having this much or this much is having this much of release of pain. So concentration of the drug itself will depend upon person to person. Okay. Next, use of adjuvant drugs. As per the WHO ladder, we have seen that for every step we have been using a adjuvant. You can or you cannot. But the thing is, whether you go to the next step, it is better to use an adjuvant if you see that if you require. We'll come to the adjuvants later. But if you feel that you need to take up an adjuvant, it is better to add an adjuvant before going on to the next step so that the patient can get a complete cure out of it. So these are added at every step for specific types of pain and to decrease the undesirable side effects and analgesics. And mind you, like I have only added very important sessions and important topics in this slide. It's not a very detailed, but each and every slide which is being, incorporated into here is very much important so that you can have one glance and can get information at a jet. And next is attention to the detail. You talk to someone, you think of a particular drug, and then you give him for his pain. But you need to have a total assessment about that patient. You have to go through every attention detail the patient says, like his age. You can't expect to give so much of load of a particular opioid, say, example, morphine, to a patient, or even a paracetamol. You may take a paracetamol by just 500 or 650, which you can take it upon yourself, but you can't expect the same thing to have the same effect on a small pediatric age group child or a teenager. So this is very important. Age of the patient, the body build, how the body is, the body habitus is very important. Which all comorbidities, the diabetes, hypertension, dyslipidemia, all the things that the patient has, side effect profiles that the patient has. So these are all very important. So these are the things which you need to understand before you start any drugs for a particular pain. So the action should go through by the mouth, by the ladder, by the clock, individualized to the patient, use of adjuvant drugs, and attention to the detail. These are very important. Kindly go through the slides when it is released. So next is non-opioid drugs. So these are the basic things which we actually go. We'll be talking about the step one, which is actually the non-opioid and the adjuvants. So non-opioid drugs or adjuvants are used only in not only in step one. This is the major thing that you need to take. This is a major take-home message today. Just because we are studying non-opioid and an adjuvant doesn't mean that you can use a strong you can't use this with a strong opioid. If you are giving morphine, I'm definitely sure that I've seen a lot of patients who are taking morphine and then paracetamol together. So this is very important because that paracetamol can do wonders in a patient who is taking a very strong opioid. So these non-opioid and adjuvants can be used in any step of our WHO ladder. So keep this in mind. This is very important. And mild to moderate cancer pain is easily a response to step one and step two drugs. And adjuvant drugs may be required depending on the type of pain. And opioids may not always be required for cancer pain. So there are a lot of stigmas which has been, emphasizing around saying that only morphine can help with cancer pain, or only strong opioids like other adjuncts of morphine, or even like methadone, or even you can talk about methadone, which is actually again a very potent drug which can be used as a strong opioid. So people can use other adjuvants and also these kinds of NSAIDs or other weak like paracetamol and other things which has been used in step one also in all the other steps. So it is very useful in understanding this. So this is yet again the other step where you have to understand that how strong that it can be. So this is actually a very new development in understanding the classification of the step pattern, where we have actually arranged another one which is called the step 4, which actually emphasizes even if you give, like I've seen a lot of patients which we, even if after giving the highest dose of morphine and highest dose of methadone, you can see the patient is still in a lot of pain. The pain hasn't been subsided, or the patient is still going through a lot of pain. And in such a thing, you can actually go in for step 4, which is actually interventional analgesic movements that actually which consist of nerve blocks or epidurals or percutaneous electric pump can be used, neuroleptic block can be used, and spinal stimulation. So many of the things which is talking, but these things are all invasive. The thing that you have seen, like taking an oral pill, is not actually related to the epidural or a nerve block. In nerve block, you have to infiltrate the nerve. You have to, give a syringe into the nerve and then nearly prick the nerve and then you have to give. So it is like more of an invasive procedure, the step 4 one. So this is being done if there is no other choice. So this is not included in the WHO like the thing, but this is the modern classification where we have a step 4 approach where we can use these also. So we'll be talking about the step 1 drugs more importantly. Okay. So these are used in mild to moderate pain, and these include, like most importantly, we use the main thing is paracetamol. So paracetamol is the one thing which we used, and the next thing is non-steroidal, that is NSAIDs, non-steroidal like anti-inflammatory drugs, and it can also be used with combined of an adjuvant drug. Adjuvant drugs will come into later. There are a lot which can be used, but majorly in step 1, the main thing that we use is paracetamol, and also these NSAIDs. Paracetamol has a very important role. Even though we just say that everybody knows about paracetamol, paracetamol is just a thing which can be used by anybody. Anybody can go to a pharmacy and just buy these paracetamol. But understanding what action does paracetamol today, the view of the thinking process that you have in your mind about paracetamol will completely change today. So this is the one thing I'm going to take you to. So the manage to mild to moderate pain, these can be helpful. So I'm talking about just the step 1, which can actually take mild to moderate pain. So mild to moderate, you can understand by the pain assessment score that we have talked yesterday, like the last class. And the first step is used with or without adjuvants. You know that all about us being, helping with adjuvants or not, which is being required. And is useful in inflammatory pain and bone pain, which is actually the NSAIDs that comes in. So if something is there in inflammatory pathology, which has some kind of an autoimmunity or any kind of inflammatory pathologies that can happen, NSAIDs are actually the best because they actually block that kind of an intervention where inflammation happens. So we'll come to that, the pathway. And paracetamol being is less anti-inflammatory, which is having a more of a central action. So NSAIDs literally have an inflammatory, action, while paracetamol doesn't have an inflammatory action. So putting these drugs, you have to keep in mind what pathology it is. So it is actually a, like a Pandora's box, which everything comes in together and you need to make something out of it. You need to cook with a lot of ingredients. You need to know what the pain is. You need to know how the pain comes in. You need to know what the pathology of that pain is. You need to understand what that pain is being caused by. And you need to understand how to deal with it. So everything comes in a big bubble. You need to understand, sort things out, and then you make a diagnosis, and then you put in a drug which actually helps in, defeating that pain. So this is the one thing which you need to understand, that in NSAIDs and paracetamol that is being discussed over here, you need to understand some basic pathology of how these things are actually acting. It is not just only the doctors need to know the hi-fi short things. I'm just there to administer the drug and let the patient have his taking out of his misery. No, you need to understand what you're putting in, right? If somebody is giving you a advice saying that just give him infusion of 1 gram paracetamol, that doesn't mean that you have to just go and put 1 gram of paracetamol. You need to understand what this paracetamol is going to go inside and do for the betterment for the patient. If you think that that particular thing is being contraindicated to this patient, you have all the right to go and say to the doctor that, doctor, this patient is having such and such problem. So isn't paracetamol contraindicated in this patient? You can. Who says that nurses or people can't go and question a doctor? You can go and question us when you think that is. So what do you need for that? You need to understand what is being done, right? So that is the reason why I just wanted to talk something about what is being done here. So there is a thing called arachidonic acid, which is actually in the basement membrane of every cells that we have been studying. What happens is that when there is a tissue destruction or a cell destruction, the destroyed cell membrane lipid will produce arachidonic acid. So this arachidonic acid is something which is being produced by the cell membranes of the free fat of the cell membranes, lipids of the cell membranes. And what happens is this arachidonic acid will go in 2 different directions that you have seen. So what happens is that one pathway of what the cytokine is produced is actually a constitutive pathway, which you can see as COX-1, cyclooxygenase. The COX is cyclooxygenase 1, and another one is cyclooxygenase 2. 2 different enzymes act in 2 different ways, which we don't have to go into detail with, okay? Let the other people study about it. But the major fact is these things are going in 2 different pathways, where one type of drug blocks one pathway and the other type of drug blocks the other pathway. So we'll talk about the types and stuff, but the major thing is what you see in constitutive pathologies are actually for housekeeping functions. Your arachidonic acid just breaks down and it goes in two different pathways. One pathway is actually for the good of the body, because you can see that when it goes into the constitutive pathway, you can say that it is actually producing thromboxane, which is actually a housekeeping functions, which actually helps in all cells. In your gastrointestinal tract, it's actually help for your mucosal protection. It can help you for the covering and maintenance of your mucosa so that nothing is being eroded and your stomach stays healthy. So this is one thing, this housekeeping function of COX-1 pathway. And another has kidney is it will increase the renal blood flow to the kidney so that it will have more of GFR is being increased and there is more of excretion. So that is also a housekeeping function. There is a thing called platelet aggregation, that the platelets in your body, whenever there is a bleeding or where there is a problem with the diastasis, the platelets will come together and form a clot and then it will cause your bleeding to stop. So that is again a housekeeping function. And the endothelium. The endothelium being perfect in the sense that it has not any cause of oxygen-free radicals or any other pathologies is also one important function. So all these are housekeeping functions. So that what does the housekeeper do in a hotel? They keep all the things right? So this is what is one thing which is being done by housekeeping function in the COX-1 pathway. So number one, housekeeping. What happens in number two? So I'll just give you one random example saying that if I give a drug, if I give a non-selective NSAID, I'll not say the examples, I'll just say the thing. If I give a drug which actually goes and block that COX-1, you can see the non-selective NSAID written there. Non-selective means it can select. It doesn't select. Wherever there is COX, it will just go and block. There is no COX-1 or COX-2. So you can see that the non-selective has actually went and blocked both COX-1 and COX-2. In cyclooxygenase 1, when it is being blocked, all the functions which are being written down there gets halt. It just gets halted, right? So what happens in mucosal protection? There is no mucosal protection right now, right? What happens? Over the time, this patient is taking something, NSAID perhaps, let's name it like ibuprofen, or let us make it say like diclofenac. If you give such a drug, what happens is over a period of time, you'll have gastric irritation. So this is the reason why doctors always prescribe an NSAID and then they write, the next thing they write is Pantop or Rantac for a gastric mucosal protection. Because over the time, what happens is this will cause your GI mucosa to erode, causing ulcers, gastritis, and even to an extent where I have seen perforation. I'm not joking, literally. When you give NSAIDs, you should be that careful. We just give NSAIDs like for 4 or 5 days. That's it, maximum of 5 days. But what happens is the patient may feel so good that he will keep on taking the NSAID. Because if you go to a pharmacy and ask diclofenac, the pharmacist will give the diclofenac. But what happens? This patient will keep on eating the diclofenac, and one fine day, he will come with a history of severe abdominal pain. And you understand that the patient is having ulcer by now, peptic ulcer or duodenal ulcer, whatever the thing, you might understand that the patient has gone through it. So the housekeeping function is being deteriorated because of these drugs. What happened for the renal blood flow? The renal blood flow is being decreased and the patient may go into a AKI, acute kidney injury. The patient may go into an acute kidney or a tubular injury at any time because of this. Again, platelet aggregation. These beings are avoided and the patient can go into bleeding. And think about the combination, the deadly combination of GI mucosal protection and the platelet aggregation factor. Just think about it. If these two things go haywire, there will be erosion, there will be ulcer at one point, and there is bleeding from there. And you can understand that the platelet is not aggregating and platelet is not doing its function. Just think that the ulcer is there, it is bleeding, and because there is no platelets, it is keep on bleeding. So what happens? Patient will complain with two basic things. One is the patient is having so much of abdominal pain, and the second thing is patient will come then with a history of melena. What is melena? Can anybody tell? What is melena?
Blood in stools.
Very
Blood in
good.
the stools.
Not particularly the blood in stool is actually the digested blood. Because blood in stool is actually, you can see the occult blood, right? You can see the fresh blood coming out. But melena is coming out like a sticky, tarish thing, right? It's coming completely black color. So what is a black color? Is actually because the RBCs are being digested by the hydrochloric acid and it will produce as well as reddish, like blackish, tarish tarry stools, okay, smelly and tarry and all. So that is the thing. So a patient with COX-1 inhibitor will present you like that. What about that COX-2? So we have talked a brief about, this is just a brief thing, okay? If you want to understand more about this, kindly just see the arachidonic pathway. Just go to YouTube or any other video sites where you can see details about all this pathway if you are interested. Okay, I just wanted you to know like what drug you are giving and where the action comes from. Just arachidonic pathway if anybody's interested, okay? So we'll go on to COX-2, which is actually related to inflammatory pathologies and inflammatory. I said that NSAIDs have an action against inflammations and stuff, right? How does that act? See, when something happens to our body, when some infections or something happens to our body has a defense mechanism for it, right? So what is that defense mechanism? It is inflammation. Inflammation occurs in the body so that the defense mechanism happens to reduce the so-called source of infection, whatever it might be. Okay. So what happens when these are being triggered? When our cell is being triggered with some infection, our cell will release so many things, which is called prostaglandins. And the main things are like cytokines. It can even be like mitogens. It can be carcinogens. Carcinogens are mainly oncogenes, and carcinogens are usually coming after, which can cause cancer, right? So when these things come in, the inflammation of our body just kicks up. And what happens? The arachidonic pathway, the COX-2, which is actually an inducible. So this path only activates when there is something which causes it to activate. It doesn't activate just like that. If arachidonic pathway is just being made because of some tissue destruction, it will only go on to path 1. That is the COX-1 way. If there is something which is inducing, you can see in red, which is being written cytokines, mitogens, and carcinogens and oncogenes, right? So when these trigger, what happens is it will go on to COX-2 pathway. And what does COX-2 pathway do? It actually produces two kinds of prostaglandins, which are very important. That is prostaglandin E2 and a prostaglandin I2. So what do these things do? There are a lot of things that you need to understand. There is also like thromboxane and other things. But I'm just going into a very superficial thing, which you need to understand. So prostaglandin E2 and I2 have very different, action, where it can cause inflammation and it can cause, other kinds of things, which is kind of like angiogenesis, cell proliferation, macrophages, sinusites. So these things are actually helping in tissue repair. It helps in tissue repair. So this is very important because you have an infection, your body goes for an inflammatory attack and your body tries to fix things up, right? So this is the way how COX-2 works. But just think, if a selective COX-2 NSAID, if we give something to block the COX-2, which I have written as COX-2 as a selective NSAID, which only goes and activates the COX-2, cyclooxygenase 2, which is only indivisible, right? Just think all the problems that can happen. The patient can go through all the problems. All the inflammation process is being disrupted. Inflammatory processes are being disrupted in every sense, so that healing doesn't take place, and all the other things are also being coherent. So it is very important in understanding that when you give these drugs, it is better to understand of what all are the adverse effects or the problems that can be faced by the patient over a long period of time. This is not like an acute thing. Just because you may say that, okay, he said that you can't give NSAID to anybody because of all this problem. It's not like that. You can give safely for a period, a very short and an effective period for that patient. It's not like you can't take it for a long time. So this is the one thing you need to take it. So this is the same thing which I have already written, but a more simplified version, where the arachidonic pathway actually goes in COX-1 and COX-2, which produces the particular prostaglandins which are being made. And one on COX-1, it's a gastric mucosal protectant and all those stuff. And on the other COX-2, it is like helping the inflammation, the fever, everything. That is one reason why. I'll just give you a very quick hint, one thing. The paracetamol that you eat for a fever, the paracetamol actually goes to that COX-2 which is written over there, and it just strikes off that COX-2. It just stops the COX-2 then and there. So what happens? Fever is actually a symptom which is actually made by your body to make you understand that, okay, why there is something problem in you. There is an infection in you, get it cleared. Get it cleared by a doctor or somebody. Okay? It is giving you a hint. Like the pain comes, like the last class I have said that pain is there for a reason. And similarly, this is for a reason. The inflammation and the fever everything is for a reason, saying that there is something abnormally happening in your body. So then when a fever person comes, you give in paracetamol and the patient has no fever. So what happens? The COX-2 is being completely triggered and being abolished. It is actually an antagonist. It just goes and blocks the COX-2 pathway so that the fever doesn't come up, the inflammation doesn't come up. So this is the action of paracetamol that we have been using for like decades. Okay. This is just a fun fact I just told you immediately so that you understand what is being done or what is being there. Okay. So we'll be talking about the king himself, the paracetamol. So these are the very important points. I have just summarized everything in a slide so that you can just read it then and there, if you want to take in. So it is predominantly, I told you, it's more of a central action where it goes and blocks the COX-2 so that all the things that we have talked, I have talked in detail. I don't have to read everything and make you guys can read it. And if you have any doubts, you can post it over the thing and we'll discuss it over the time. So there is no effect of peripheral COX, so hence less side effects. So that is, we have understand that the COX-1, which is in the periphery and everything, so it doesn't go and affect the COX-1 so that GI bleed problems and other things, these things doesn't happen. It won't affect your kidney. It does affect your liver, but it won't affect your kidney. So there is no blood flow issues there. There is no problem with having a gastric bleeding or something with a paracetamol. And also it has other effects also. Not only with the inflammation, it has also antipyretic. It will bring down your fever, right? It is anti-inflammatory, it is antipyretic, and also it is an analgesic. Because this COX is being avoided, all the inflammation goes down and the pain also goes down. That is one important thing in understanding that it brings down a lot of stuff. So literally paracetamol is actually a king, in understanding when it comes to pain, you need to understand that it is a very good drug. And it is actually, it is actually safe up to a dose of even 4 grams. It can give 4 grams, and we usually give like 1 gram IV infusion, right? You can continue that for 4 times a day. So totally of 4 grams can be actually put in, and more than that, it is actually taken as a adverse drug issues. Not the fatal, but it is just give other side effects. That's you can start to see side effects of paracetamol. In that way, you won't be dead if you are given like 5 grams. But the major dose, that the daily dose, you have to keep it under 4 grams. Okay. So the potential is very high for hepatotoxicity. That's one thing you need to take in. Just because that I have said that paracetamol is very safe, you can't just give on paracetamol to everybody. It is very hepatotoxicity over the time or over the concentration that is being returned. It's also very safe in liver disease, and up to around like 2 to 3. You can even give to 2 to 3 grams a day. So even if you have a liver disease like a CLD, you know about chronic liver disease, and all those cases you can actually give a paracetamol, which is actually 2 to 3 grams a day, and is very safety. The safety is pretty good in paracetamol. You can just close your eyes and then give paracetamol unless and until you know what you're dealing with. So it is a very good safety profile, and then it is undesirable effects are very, very uncommon. So very uncommon. And there is no adverse effect on gastric mucosa because we know the reason. It's not just saying a statement and then ending it. You say the statement and you just think of why. Why was the gastric mucosa effect spared? Because it is related to COX-1 thing, right? And paracetamol has nothing to do with COX-1. It has to do with COX-2. Okay. So there is no adverse effect on gastric mucosa, well tolerated by patients with peptic ulcer disease. Isn't that so good to understand? And there is no adverse renal effects also because we know the answer. And there is no effect on platelet function. Okay, we know the answer for that too. So this is so that is the reason why I brought in this figure. It's so important. Okay. So paracetamol is actually the mainstay drug of WHO analysis ladder because of its following advantage. So I'm talking about the advantages. One is, yes, the thing is, it is safety. It is all about safety. You give a drug to a patient who's already in so much of agony and pain, and then after 5 or 7 days, he comes back saying that I have so much of stomachache. He comes with a headache, and you give him an NSAID, and like after 7 days, he'll come back saying that I have now stomachache. My headache is okay. I have the migraine is okay, but I have now stomachache. He'll clench his belly and then he'll come. So this is one thing you need to understand. When giving analgesics, it is very important to identify what drug you are using and in which condition you are using. So it is very important. So as per paracetamol, it is very important to understand that it has a very high ceiling of safety profile. And the other is it has opioid sparing effect. Can anybody say what opioid sparing effect is? Anybody? I'm going to just wait for like 30 seconds. If anybody has an idea of what opioid sparing effect is, let's make it more interactive. Last class was much more interactive than this. What happened today? Everybody sleepy after the lunch? Can anybody say what opioid sparing effect is? Okay, Maria says not sure. Okay. Don't worry, Maria, I'm there for it. Anybody else? Okay, we'll go according to it. So, what is opioid sparing? I literally told in the starting of this class, I literally started with starting in this class. Like, what is the sparing thing? You give an opioid, which is very strong. Okay, you give it up to this much. You give 100, and then you understand that this patient is having so much trouble taking this whole 100, and then you put in some other drug to help this drug, right? You understand that the most senior most doctors need their house surgeons or the staff students to help them, to support them, so that the burden comes down. So this is the same thing here. There is an opioid which is a very high opioid. So let's say morphine. You take in morphine, and then you need to take in a very high dose of morphine to bring down so much of pain. Like you need this much of morphine to reduce the pain from 100 to 50. But if you use a paracetamol with this thing, what happens is that you will reduce the morphine. You only might need only like half the dose of the morphine with this paracetamol, so that they together can bring the pain of 100 to 50 with this two different doses of the two different drugs that we use. So this is more of a polypharmacy, but still, yes, if we can bring the dose of so-called big high shot drugs down, it is much good. Taking in more morphine is not going to be good for you, right? So if we can help the aiding thing, the aiding effect, it is called the opioid sparing effect. You spare the opioid. Okay, you needed 100, now only you need 50, because the other drug which we are being used with the opioid will help the opioid in achieving its goal to reduce the pain by some amount of percentage. Okay, is it clear? Those who have written don't know, can you just say whether it is clear or not, or whether I have to explain it again? The opioid sparing effect. Would you please say it fast? Okay, Jyoshna has said it is clear. I think if Jyoshna is clear. Okay, Reena has also said that it's clear. Okay, Maria. Okay, thank you, everybody. Okay, so this is the opioid sparing effect that you need to see. So paracetamol is one of a major wonder drug where it has shown opioid sparing effects. So you can use it with the opioids. So don't think that some doctor has written morphine and right under it he have written paracetamol. So if morphine is there, what is the role of the small chucha like paracetamol under here? So this is very important stuff that paracetamol can help there. So that is the reason why I called it wonder drug. The next is it is added to all the steps of the ladder as a combination. You can see that it is like everywhere it has been stepped. Whether you have like step one is like basically NSAIDs, but paracetamol can be put in with the NSAIDs. If it is being second step where we use light opioids, weaker opioids, that you will study in the next session. There has been like tramadol or any other thing, codeine, which being used concurrently with paracetamol. It has also giving effect. And also in step three, where you use the high opioids, right? You use methadone, you use morphine, whatever you use up there, paracetamol can still help in one or the other way. So this is very important. So we'll come into the next topic. There is NSAID. I think there is no doubt about paracetamol. Just post your queries. We'll talk about it later. Okay. We'll come into NSAIDs. So NSAIDs is actually exerts its therapeutic effects by inhibiting the enzyme of peripheral cyclo. In peripheral cyclo, can anybody say which is the peripheral cyclooxygenase? COX1 or COX2? Let me just take a revision so that you people get. Okay, Ashwati, you have asked for a, please repeat the thing of opioid sparing. By the time the people answer, I'll just talk about the opioid sparing again. Ashwati, the thing is, when you have to give so much amount of opioid, let's say you have to give 100 morphine. I'm not saying the right values, I'm just giving up some other values. You have to give 100 morphine to a patient to bring his pain from 100 to 50. Okay? But you have a paracetamol with you. So what you do is that you give 50 of paracetamol and you give 50 of, say, whatever, 50 of paracetamol and 50 of morphine. The only thing is you have reduced the concentration of morphine. From 100, you have brought down to 50. So this 100 alone could actually bring down the pain from 100 to 50. The pain of 100 to 50, the 100 of morphine could do it. But now I am only using 50 of morphine and I'm using some amount of paracetamol with it. So what happens is with the help of this paracetamol, this 50 of morphine is actually able to bring down the pain from 100 to 50, which only the morphine was able to do at a rate of like 100 mg. Okay. So 100 of morphine could only bring down 100 to 50, but with the help of paracetamol, what happened is now it is just a dose of 50 mg. It can bring down the pain from 100 to 50 because paracetamol is helping. So opioid is being spared from 100 to 50. 100 mg of opioid is not necessary, only 50 is necessary. So the rest 50 is being spared with the help of who? Paracetamol. Is it clear, Ashwati? Can you say, Ashwati? Is it clear? Yes, it is. Okay. So nobody has actually answered. NSAID exerts a therapeutic effect on I said cyclooxygenase of periphery, right? COX? Yes, yes. So everybody was waiting for Ashwati, I guess. Okay, so it is COX-1. So COX-1 is the one which is acting as inhibition of exine, and this action is actually for the periphery cyclooxygenase. So now you can understand why I was saying when you give a lot of NSAIDs, it will affect your kidney, it will affect your GI, it will affect all the other basic things, it will affect the bleeding. So all these things are very important in understanding that where it is going to affect or where it's not. So this is an important enzyme, which is arachidonic acid, which we have already talked about. And then these are the basics. This is the reason why I wanted you to know everything about this. So it also produces tissue and inflammatory prostaglandins are there produced. And then prostaglandins are important intermediates in pain and inflammation, which we have already discussed, and particularly useful in nociceptive pain associated with inflammation. So if inflammation comes to your mind, NSAID is the next thing which should come to your mind. So the basic thing which you need to understand are the adverse effects. So even if a doctor gives you a prescription of an NSAID that runs for 14 to 15 or like 1 month, you need to question. At least just question, even if you don't know what all are going for the patient, just go and just ask, sir, this is an NSAID. I have studied that giving NSAIDs for such a long period. Don't go and ask for people who are already written like 5 or 7 days, okay? Okay, so Hema has actually asked to repeat the previous slide. There's nothing, Hema. The thing is that the cyclooxygenase 1 is being affected in NSAIDs, so that all the things that we have discussed earlier, this thing is being inhibited, right? The gastric mucosa are being affected. Your platelet aggregation is being affected. So everything that we have studied here. So this is the thing. This is the COX-1 is being affected, right? All the constitutive symptoms are being affected, Hema.
My question is like COX-2 is for the, COX-1 is actually not the peripheral one, right? It
Which
is
one?
written in the slide which we are showing now, the NSAID. It is written like peripheral. No, the another one.
No, where?
The peripheral side, COX. So that is what like I don't
No, no, no.
understand the first line.
The thing is, what I'm talking about is, see, the central action, we know that the central action always goes to the COX-2, right? Because paracetamol we have
Yes.
just studied. We have just studied that the paracetamol here actually acts upon the COX-2.
That is COX-2. Paracetamol acts on COX-2.
That is
That I
central.
understand. That I know.
Yeah.
But what my question is like in this thing, the NSAIDs exerts a therapeutic effect on by inhibiting the enzyme peripheral COX. So here I don't understand the peripheral COX. The line is okay. The therapeutic effect is like if the COX-1 is inhibited, the therapeutic effect will be inhibited by NSAID. That is what you meant by this line,
No,
right?
the thing is, see, how does it affect? The therapeutic effect is the effect which we need, right? What is the effect that we need? It needs some effects which is acting on both. So most of the things, most of the NSAIDs actually act by this one. you have seen that it is acting on both. So non-selective NSAIDs, which act on both, which is
Okay.
actually having more of a COX-1 and more of a COX-2. So it depends upon the drug. So that is being a different classification. You will identify the class. Nothing is like it will act only on COX-1, or there is nothing which acts both on COX-1 and 2. You don't have any drugs which is actually acting like completely like a constitutive. We don't want that, right? We don't want a thing which destroys the housekeeping functions. We don't want any drug which directly goes and it completely destroys your mucosa. You don't destroy your kidney, destroy your bleeding. You don't want that, right? So housekeeping functions is for COX-1, but the problem is when you give NSAIDs, which affects the COX-2, there are some NSAIDs which go and inhibit the COX-1. So even if there is a good thing about NSAID that it will reduce the inflammation, it will help you with a lot of pain, a lot of fever, a lot of other things which are related to inflammation. There are some group of NSAIDs that will go and affect the COX-1. You can
Yes,
see
sir. Those
that.
things I could, yeah, those things I could understand. But the only thing I wasn't like sure about is like peripheral COX. That is the thing I just
Peripheral
got
COX. Peripheral
confused
COX
about.
is what I meant is like COX-1.
Okay.
Yeah,
That is
that's the
what I
one which I
got
was talking
confused. Like
about.
COX-1 actually, the
Oh, you
constitutive
misunderstood the
pathway.
term which I used. Okay, okay, sorry for
Yes,
that.
that
Okay,
is
fine,
what
fine.
I
No, it's okay,
understood
it's
that.
okay. No, so the peripheral COX that we have written here is that I have said central. So that is the reason why I said peripheral. I said
Okay, sir.
central COX, which is like COX-2, and I have written, that is the reason why I asked the question also, right? What is peripheral COX? And everybody has written COX-1 also.
Okay, sir.
So
Okay.
that is the thing. Okay, I think I have dealt with him. So the thing is, the adverse effects. This was what I want, and you need to understand that what adverse effects of NSAIDs are. So this is one thing you need to understand. The first and the foremost is the gastric irritation. Next will be the renal toxicity. I don't need to. I think I don't need to explain much of this because we have already dealt with the basic thing. And diminished platelet acidosis, anything, the next thing. And since one more thing is there, that since it is affecting the inflammation may go in various patterns. You know that anaphylactic reactions are directly or indirectly affected with all the inflammation in your body. So it can trigger up the inflammation at any sites, and that can even lead to anaphylactic reactions. And the symptoms can be like nausea, pain, bloating, dyspepsia, bleeding, and all those kinds of things. You might know why nausea, pain, bloating, because of the gastric ulcer. Dyspepsia again for the gastric ulcer, bleeding because of the ulcer. So these are the things that can happen. And long-term NSAID is like four-fold higher risk of GI bleeding. That is very important. But the lesser is the risk with COX-2. Why? This is the central acting. The inflammation is just being reduced. So there is a central acting and we don't have a problem with COX-2. So this is where I need you to understand what COX-1, COX-2, will the drug affect only COX-2 or whether the drug is going to affect COX-2 and COX-1. So this is a new thing which you need to understand, and please go back, see this image, stamp it in your mind. So this is the thing what I have been talking about. Okay. So we'll just speed up. So the current recommendations now, which has been written as ibuprofen, which is one among the NSAIDs, with aspirin may decrease the cardioprotective effect of aspirin. So aspirin itself, we know that it has a NSAID which is actually acting in a base where it is having, what is aspirin given for? We all know that it is given for cardiovascular diseases, right? We have been given patients with aspirin and clopidogrel and also. Aspirin itself will help in thinning out by blocking the COX-1, right? It will be causing the COX-1. The aspirin will go and it will affect the COX-1. What happens when it goes to COX-1 and it will inhibit the COX-1? There will be gastritis. The patient will present you with gastritis who is taking aspirin for a long time. So if you see a next patient who comes in with a like a stroke patient or an MI patient, if you can just ask him who is on like aspirin, you can ask him like if you have any abdominal pain or cramps or something like that, he will say yes. If he's not on any other like PPIs or anything, pantoprazole or Rantac or something like that, he will say that he's having gastric irritations. But why did we give, even though we know that this is going to happen, why are we giving? Because of the platelet aggregation. We don't want the platelet aggregation to happen for the thrombus formation of myocardial infarction or a stroke. We don't want that. So this is where, doctors or medical field professionals will weigh the importance of whether this will do good, more good than the harm. See, more good is being done than the harm. So the harm can be just kept aside. We know that the drug can cause harm. So this is one thing. So recent studies have actually said that when you give both, like ibuprofen and aspirin, it will decrease the cardioprotective effect of the aspirin. And if aspirin and ibuprofen are taken, like take ibuprofen at least 30 minutes prior to aspirin. So if you see a patient, these are all just factual things which you need to understand. So that these are the take-home messages, because in everyday practice, you might be seeing a patient who is having, aspirin with them, and then he's taking ibuprofen. Tell him that, sir, can you please take it like 30 minutes prior to taking aspirin? This is a wonderful thing, right? And chance of gastric mucosal damage with aspirin and other NSAIDs is very, 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 very high. It's very high because both are completely occluding the COX-1, which is can cause huge issues. And if the patient does not have a satisfactory clinical response to full dose, that is up to 400 of acetaminophen. What is acetaminophen, by the way? Does anybody know what acetaminophen is? I have put different names to, make you. Yeah, very good, very good. Jyoti, very good. It is paracetamol. It is the thing is paracetamol. Okay, acetaminophen is paracetamol. And if you have given like the complete dose of paracetamol, you can't give any more. You can't give already you have talked about 4 grams a day. You can't give any more. Then only, oral NSAIDs have to be used. Then only it has to be used. Except for people who are like more than 75 years of age, like these people I have already told, they are in extremes of their age. They're in extremes of their age, and when they come to you, you're giving them NSAIDs. The next thing is that you give for 5 days itself, the people will complain of, renal failure and other things. So unless and until it is an extreme of age, where you can see a lot of, old age people coming for diclofenac gel and all, you can use those NSAIDs as topical. Don't give it like systemic, because if you give in old age systemic, you have all these things will be, more important. So this is the one thing you need to take away here. Okay. So there is one important thing also you need to think. I have already said that NSAIDs can be given, but the one thing is strict avoidance of NSAIDs among patients with chronic inflammatory disorders and vascular risk factor may not always justify when the patient places a high value on the control of symptoms and understands the magnitude of associated risk. Lot is written, right? The basic thing is, if you have a problem saying that, okay, this NSAID will have these much of adverse effects on you. But when you take into consideration about the patient, if he has pain, let alone let all these adverse effects, let them go to hell. The pain is the major thing which is the patient is going through hell right now. If the patient is in pain. So that is the reason why, even if we say a lot of bad things about NSAIDs, NSAIDs do help in a lot of ways. NSAIDs do help in a lot of ways in decreasing the pain to very certain extents, that even in terminal illness, where there are multiple metastatic bone lesions, even when the bone pain is there, opioid has a further, a only a restricted role in having solace to a bone pain. But mind you, NSAIDs can help there. NSAIDs can go and help for bone pain in various sense. So this is something you need to take in. Just because I have said that NSAID is a not good thing, it is not justified. It can be used in control of various symptoms, with understanding what the magnitude of the associated risks are. Okay, you have to take in the risks also before giving NSAIDs in a people who don't have any other thing. So now we'll be talking about adjuvant analytics, which are pretty important, but I don't think it is so much needed thing as for a whole thing which have been seen. So any drug that has a primary indication other than the pain, but analgesic in some of the other pain, this is called the adjuvant. I have already said, like, it is adjuvant. It is helping in nature. Okay. So in step 1, we can see in non-opioid analgesics or crossover adjuvant is being used. That's mildly for mild intentions of pain. And in step 2 also, it is mild to moderate. And in step 3, we'll go to a much higher things. So in the next class of your opioids also, the doctor might say that it might help with the adjuvants. So don't go bonkers thinking what adjuvant is. So it is very important going through few adjuvants that I think is very important for you on a long run. So this also has a pretty good stepwise approach where you can understand how these adjuvants can help you. I told there are a lot of inflammations happening here. Lot of inflammations are happening, and that causes pain, right? So the first thing is corticosteroids. Steroids itself will bring down the pain. It will bring down all this. This particular image which I have showed here, the can't use mouse in here. Can they see the mouse? If I use the mouse here, can they see the mouse? Yes, they can. So what happens is we have written that the NSAIDs will act only in the cyclooxygenase pathway, right? Somewhere here and here. What happens when you give steroids? They will directly go and inhibit right here. So what happens is the arachidonic pathway is not even being proceeded further. So this is the one thing which helps in taking out your pain. So this is very important. So that is the reason why in step 1, what happens is we directly start with corticosteroids. And then there are a class of drugs which is called tricyclic antidepressants, which will be having amitriptyline as some examples. And then we have anti-epileptic. You have heard about gabapentin, pregabalin, and everything. Stop me if you feel that you are not getting anything through, okay? And again, in step 3, we can again hike the doses of these tricyclic antidepressants and everything that I have talked about. And then we go on to NMDA receptor antagonist, channel blockers. And then again, if nothing is happening, again, it will go to spinal anesthesia or spinal analgesia, which is actually being seen in the WHO ladder also. This is just a basic thing. You don't have to go, pretty detailed into it. It's just the one thing which I wanted to show you. That's it. This also has using adjuvant also has a stepwise approach. Okay. So where to use? You have understood that you need to use an adjuvant for it. So where to use is the most important thing. Maria, step 4 is the same thing, which is spinal analgesia, which when directly used here also. We have already seen in here where I have used the same stepwise approach. Yeah, I said about a new classification where we have introduced the step 4, where you can use spinal blocks, epidurals, percutaneous activity pumps, neurolytic block therapy, and everything. These are the basic things which you can use there also. If nothing is working, we have already said that these are the drugs, opioids, analgesics, and everything, which has been drugs which being used. And if now no drugs are activating, we'll go to procedures. Like the same is being applicable here also. You work throughout the drugs. You go for corticosteroids, you go for tricyclics, and then you go for NMDA antagonist, and then everything works up and nothing happens, and then you have to jump onto spinal analgesia. That is everything, nerve blocks and other things that we have to. For the spinal anesthesia, like we give the blocks to the roots so that no sensations goes in, and then the patient can have relief. These are the interventions that we usually use. I think it's clear. Maria, is it clear? Okay, fine, thank you. So where to use? This is very important. So where to use all these things? So amputation, patient is having phantom limb pain, sciatica, back pain or leg pain or hip pain or wherever the pain is, cancer pain, diabetes. In diabetes, what I meant is diabetic neuropathy, trigeminal neuralgia, HIV infected or people with AIDS who are having problems, herpes zoster, complex regional pain syndromes, cerebrovascular accidents. You have read all these things, right? Can you say what is one thing common among them? What is the part which is being affected in like most of these, not like everything, but most of these, one particular thing is being involved. What is that? In phantom limb pain, the cancer pain, the sciatica pain, the diabetic neuropathy pain. I have given you the clue also. The neuropathic pain, the trigeminal neuralgia, all this. What is being affected? Yes, very good, Jyoti, very good. It is the nerves. Yes, it is nerves. Maria, you're also right. It is nerves. So the nerves are being used and the problem here. So what do we do in this? Vinisha, yes, it's nerve. So all these pains are things which can be all the things that we have discussed here: the corticosteroids, the tricyclic antidepressants, the anti-epileptics, the NMDAs. All the receptors are there in the nerves, so that all these problems or all these symptoms can be given direct involvement into it. Okay. So we have talked about nerves. So in the first class itself, I have already told that what the nerve is doing, what all the fibers. I have talked about the fibers, right? A delta and C fibers, which take in all the sensations. So A beta fiber, which takes in non-noxious. This is also a very important diagram. Please have it in your mind. A non-noxious or mechanical stimulations are being taken up by the A beta. Noxious and mechanical stimulants are taken in by the A delta, and the noxious and the chemical stimuli. That is, just keep in mind that A delta is a fast fiber which takes in fast pain, shooting pain, lancinating, shooting, that kind of a pain, and a very slow pain is being taken up by the C fibers. Just the people will come and say that I have a sensation of something burning here. or I feel like, some chili has been applied here. These kinds of pain is taken up by the C fibers. So what are the common sensations? How will the patient come to you? You are going to put a adjuvant with the main drug that you are being given for the pain, right? You are going to give an adjuvant. So what are the common sensations that are being seen? The patient will come with analgesia. It's also an abnormal sensation. Hyposthesia, don't feel that much of a pain. Hyperesthesia, you feel a lot of pain. Dysesthesia, we have already talked about it. Hypoalgesia, we have already talked about it. Hyperalgesia, already talked about it. Allodynia. Can anybody recollect what allodynia is? Anyone? Can you please speed up? Can anyone talk what allodynia is? Just in one word, one or two words. What allodynia is? Pain with feather. Yeah, that is a normal sensation. Yes, a very non-harmful. Yes, very right. Very right, Jyoti. Maria, you're also right. You just gave it an example, Maria. That is good. Okay, shallow pain. Okay, aggravating and harmless stimuli. Yeah, harmless stimuli. This is a stimuli which I'm wearing my clothes, but still I'm feeling a lot of pain moving here and there because this cloth is rubbing against my body and I feel a lot of pain. This is very important. Okay. So what are the drawbacks? We have already talked about the common sensations, but what are usually the drawbacks of using all these kinds of, we have already talked about the adjuvants being analgesics. This is the most important thing. We are talking about adjuvant being analgesics, but what are the drawbacks in using these adjuvants? The drawbacks are less reliable as an analgesic than opioid. They can't be given just like that to reduce the pain. You can't just give amitriptyline for the pain to have a self-relief. You need to add on with something else. Obviously, in shorter durations and in shorter symptoms, these might help in its own way, but in the other way, it might help with the drug always. That is the reason why these are adjuvants. Okay, so the pain analgesics is usually than the opioids. These are very less reliable. Will take weeks to attain an adequate analgesia in 50% of the patients, and low initial dose and titration will delay the analgesia. Why? Because it may be because lower dose of escalation to avoid the side effects. You are giving, for example, we'll talk about an anti-epileptic, which everybody knows, gabapentin, right? If you give gabapentin 100 or if you give gabapentin 300, you just start on with 100 and the next day patient will come to you saying that I felt so dizzy, I felt so sleepy, I don't want to take this drug anymore. So what do? We go from the lowest possible dose. So understand that this particular dose for a particular patient, because you have already known that the other patient I knew was taking gabapentin 300 3 times daily. He was taking in like 900 mgs of gabapentin a day. Then he didn't have this problem, and I just gave 100 mg to this patient, and this patient is drowsy all the time. So this is very important. So low initial doses and titration will delay the analgesia. In other patients, what happens is that if you start with a low dose, you ask him to come like after 3 days, and again he's saying that my pain is not relieved. You increase the dose. The cycle goes on, and the patient doesn't have a proper analgesic effect. Okay, so this is very important. And selection of all these adjuvants depend upon the characteristics of pain. And these are the characteristics. These are the particular characteristics that I have been talking about. So this is very important. So adjuvant analysis, what are the major classes? I will be just rushing off through the classes because these are very important. Still, these are from a particular point of view being, from your point of view, it is not much, but still you need to understand. I want you to understand all the drugs so that you don't go bonkers when somebody prescribes you this or you have to give this to a patient. You should know what you're giving to a patient, okay? So we have multi-purpose adjuvant analgesics. We have adjuvants for neuropathic pain. We have topical analgesics. We have adjuvants for bone pain. We have adjuvants for bowel obstruction. We have all these kinds of things. We'll be talking about some adjuvants and where it has been used. So as analgesics for pain, what do we use for pain? If somebody comes with a diabetes and then he's saying that I have pain throughout my legs. I have both the legs are like on fire. I have so much of shooting pain, lancinating pain, pins and pricking type of pain. So these kinds of things comes in. The neuropathic pain types of thing comes to patient's symptom. So when you add these to the symptoms, you understand that, okay, this pain is because of diabetes, but the thing is, this has to be taken care of because it's a neuropathic pain. So what do? You can put in tricyclic antidepressants like amitriptyline, imipramine, nortriptyline can be used in this. And the other ways, alpha-2 antagonists can be used. So clonidine is one of an example of alpha-2 antagonist, agonist. And you can even use corticosteroids, which actually happens dexamethasone and prednisolone. So when you come in and see, there are a lot of drugs which are being used as adjuvant analgesics in palliative care. You might see amitriptyline being written to the patient. You might see clonidine. You might be seeing dexamethasone, prednisolone. A lot of things can be seen with the major drugs that are being written with the patient. So that is very important. So this is adjuvant analgesics for helping for reducing the pain. Also, we can use SNRIs, which is actually duloxetine as an example for an SNRI. So you can use anything. You can use even SSRIs, like fluoxetine, you can use for SSRI. So all the, things can be added just to relieve the pain or to bring down the effect of opioid. That the opioid sparing effects can be done. So the next is neuropathic pain. This is again an important thing. This is the first thing which I've been told about the diabetic patient. For a neuropathic pain this patient is having, we can use antidepressants, we can use anticonvulsants. Anticonvulsants are the things which I have been talking, gabapentin, everything. Antidepressants are tricyclic antidepressants. This one, the first one, tricyclic antidepressants. It has antidepressant action also. So tricyclic antidepressants, the anticonvulsants, corticosteroid, and other drugs which are actually like oral and parenteral sodium channel blockers can be used, and NMDA blockers can be used. So these are the things which actually can be. You will study about each and everything much more detailed in your settings or in other classes which I've been following. And the next is topical analgesics. I've talked about, so many people who are like, old, and then these people come with, I want DFO gel, I want diclofenac gel, just because it is giving a so-called heat sensation or, burning sensation, which will bring down that initial pain they have. So that is very important. So local anesthetics can be used. NSAIDs like diclofenac gel can be used. Again, capsaicin is again one of other, like so-called heating effect which can have, which is seen in usually, you get the capsaicin effect also. People who are having diabetes will come to you saying that I am having burning like sensation here. So that is very important. And again, for bone pain, bisphosphonates can be used, radiation can be used, corticosteroids again. So you can see that corticosteroid is like everywhere. Har jagah hai, like this corticosteroid is like. So this is very important. So it itself says why corticosteroid is so important. I just said that corticosteroid directly goes and affects the topmost part of the arachidonic acid gradient. This is very important. So do understand that. So it affects somewhere here. So that is the reason corticosteroid is very important. Okay. So we'll go to the corticosteroid. So I'm just talking about corticosteroids which will be used everywhere, right? So what is the thing with corticosteroids? क्यों इतना बड़ा ज़्यादा दे रहा हूँ corticosteroids के लिए, है ना? So the corticosteroid here is only used when the nerve compression is present. And why? Because I told you the one thing is inflammation, and inflammation has so many parts, right? You have been reading that inflammation gives you rubor, calor, dollar. So many of things are there. So in one thing is it will have edema, right? If a mosquito just bites you here, there is a big hump, and that hump is a local edema. That edema can be that edema is a part of inflammation, and if you block the inflammation, the edema will subside down. That is very important, right? So what happens is when you give corticosteroids, the whole of the inflammation comes down, and all the things associated with the inflammation, your fever, your edema, whatever fluid is being accumulated, that won't happen. The pain, everything comes down. The swelling, the redness, everything will come down. So this is the most important thing with corticosteroids. So it is only what happens is that I've talked about the edema, right? So what happens in nerve compression is the nerve is being compressed and it is in inflammation. So what happens is that there is a big edema around the nerve also. It is going through a small hole like vertebra, and then it has edema over it. When you give corticosteroid, the edema subsides down. So there is much more room inside it, and you have nerve compression is being aggravated because of that. So that is one thing. So reduces the peritumor edema and it shrinks the tumor. And what is the action? I already told that it is being inhibiting all the prostaglandin production, right? So what happened? Inflammations come down. The capillary permeability. The edema is because of the capillary permeability. More of fluid is being gushing out through your capillaries, and that is the reason why you have edema. So what happens? The capillary permeability auto decreases, and that reduces the peritubular edema. So edema also decreases because of it. And membrane stabilization is there, and there is less neuronal excitability. So everything as a whole, the big short one is corticosteroid in all those kinds of inflammatory pathologies. Okay. So rational use of polypharmacy. Polypharmacy is use of multiple drugs in various sources. But if it is rational, if you think that okay, this thing can help in such a way, rational polypharmacy is actually necessary. It is often necessary to use a polypharmacy method. And multimodal approach to treatment is mostly effective where we have used multiple drugs and multiple methods in identifying and treating the pain. And one thing is, these are all stigmas. I'm trying to break most of the stigmas in community and within us health professionals. Expensive drugs does not mean a very better or a best efficacy. You might think that a so-called drug, which is so much of cost, will give you the highest potency. No, a simple paracetamol can give you much more relief than that, right? So break that stigma, thinking that only the expensive drugs can give you the best efficacy. No, right? And you obviously should have a realistic goal. The only goal is reduce the patient's suffering, reduce the patient pain. And when you do that, the rationale for putting each and every drug is very important. So that rationale has to be kept by you people, because even if doctors prescribe irrationally, you are the people who should go and ask. You are the nursing carers. You should care for it. You should care for the patient. And if that asks for a question to the doctor, you should ask it. Don't feel bad about it. Okay. So have a realistic goal upon that, and it will better help in most of the modalities. So I think that is done with my class. Do you have any questions? Anybody? I'll just give you 1 minute. If anybody has a question, we'll discuss upon that. I think we are already running late. If anybody has a question, please start typing on.
Thank you, Dr. Aravind, for the wonderful session. I think
nobody has a question.
Yes, yes. It is clear.
Okay, how was the class then? It was good.
I think it's good. It's
Okay.
clear.
Yeah.
So I think we can move on to the case presentation part. So we have a patient story. This will be presented by Ms. Anvesha Das. So to you.
Anusha, you can start the story.
Good afternoon, ma'am. Good afternoon, sir. Patient details: age 52 years, gender female, diagnosis clear breast, present in bilateral hand, severe wounds at night, and pain in chest wall is mild and intermittent. Insomnia is present and anorexia is present. History of illness. Examination. Patient was alert, conscious, and oriented. Her body weight 59 kg. Vital signs: temperature 98.7 degree Fahrenheit, pulse 76 beats per minute, respiration 20 beats per minute, BP 130/80 millimeter of mercury. The next one, treatment and significant investigation. Investigation: hemoglobin 12.3 gram per dl, and TLC 6,800 cm, platelet 1.6 lakh and cmm, serum and vitamin D3 76.26 mg per ml, urea 29, creatinine 0.9, uric acid 4.7 mg per dl, USG bilateral blaze normal study. Treatment: chemotherapy is done 8 tablet trabitazole, 1 tablet OD, and 2 continue. Tablet Omage 40 mg, 1 tablet ODAC, 7 days, and tablet Selcal HD 1 tablet BG continue. Tablet Preglabatin 75 mg 1 tablet OD 4 days 4 weeks. Tablet PCM 1 gram 1 tablet TDS 7 days. Psychological aspect. 52 years old unmarried woman living with her elder brother and sister-in-law in their own house. Her brother is a driver and the only earning member of this family. Monthly income 5,000. She communicates with cell phone with us. She shared about her diagnosis and further depressed. She anxious about her pain and bilateral hand and tingling sensation. Medication, tablet labetalol 1 tablet OD continue, tablet Omage 40 mg, tablet 1 tablet ODAC 7 days, tablet Selcal 1 tablet BD continue, and tablet Preglabatin 75 mg 1 tablet OD 4 weeks, tablet PCM 1 gram TDS continue. Discussion point. Summary. My patient, 59 years old, diagnosis, CA-based right, modified radical mastectomy done. Radical mastectomy done on 2022, followed by lumpectomy. Now she is treated at Arjikot Medical College and Hospital on palliative OPD. Her chief complaint, bilateral hand pain. Medicine gives for pain management. Plan for the evaluation pain on next visit. Discussion point. How long pain is presented? Ma'am, actually, I will not mention two more points. Yes. Hello.
Question, can you please repeat? Hello.
Hello, ma'am.
I know, sure. This is the discussion points that we got from your presentation.
Ma'am, I can't hear properly.
Actually, these are the discussion points that we got from your presentation.
Yeah, ma'am. Actually, I will mention more points.
Yes,
but
that's with the next slide.
I cannot mention here. But
yeah. So Anvesha, this is enough. We need to discuss with the patient story. This is enough. We will talk later on that the next slide. So we need to discuss among with the team. So this is enough. So we need to discuss. That is why we we have deleted that part. Okay, so no worry. So we will discuss these points and share later.
Another discussion point, I noted it in my notebook. Can I explain?
Yeah, yes, sure.
Thank you, ma'am. Discussion point is how long pain is persistent. Then the chronic pain is one of the major devastation complication after surgery, and common procedure such as mastectomy have an incident of persistence. Post surgery pain of the 20 to 50% the patient. And exercise is effective for this pain management, and yoga, weight, and as well doing the cycling and is very effective for pain management.
So that all things we will discuss. Thank you for the patient story. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So now I hope this presentation is clear to everyone. So now we got two classes. One is about pain, and today we learned about the management of pain. So this is the patient story. So we would like to hear from you all. Do you think these patients, the pain, that management is enough, or do we need to do something more? You can unmute yourself and talk, or you can put your answers in the chat box. Answers. Yes. As Jyoti said, sure, palliative care is need for this patient too. We should give palliative care to this patient. So my question is, this patient is having pain. Do you think this pain management is enough, or do we need to add anything? Do you have any suggestions, please? We need to help Anvesha for helping this patient. So your ideas also welcome. You have to suggest something. So Jyoti ma'am said if the pain is persist, we can go for third step of pain ladder, that is in opioids. So what do you think, Sister Anvesha? The patient's pain relief is adequate, the patient is not getting adequate pain relief or not. So what I understand from your patient story is this patient is not getting adequate pain relief, especially at night. So do you want to add anything more about the pain? So the pain assessment part. No. So please go back that presentation, that slide, the physical assessment part. Previous. Next, yes. So I would like to hear from you about the pain assessment. You are mentioning about bilateral and severe bursts at night pain. So what kind of pain? What is the pain score? That all things I want to know. Dr. Aravind, what do you think? So now the pain assessment class is over. We need a better pain assessment PPTs. I think that's why I'm asking.
No, actually, the main thing is that understanding the patient's pain is much more important. But understanding the pain in a way sense, how you can understand is the most important question that you need to ask. Whether it's just by putting some questionnaires, or the patient can't tell you that I'm having this much of a pain. So it has to be asked in a proper way, in a proper channel, which makes you understand that, okay, this is the way how I need to, ask the pain. And psychological support, yes, Reena, I was just about to talk about it. Yes. And psychological support is very much needed because the patient who comes to you in an OP, he might tell so much of pain, which you might think that there's no potential nociceptive, pain pathways that has been triggering or something like that. But still, the patient complains of a lot of pain, and that pain might be a psychological pain. It might be a psychological pain. You talk to them for like 2 hours, they come in with 10 on 10 pain, and then they just walk out of the OP very happily. So this is very important in assessment of pain, and I think assessment part has to be taken more importantly rather than the treating part. You need to understand what the yes, you need to understand the feelings. Yes, Priyanka, you're right. You need to understand what the feelings are going through. Just think on your part. You are hurt. You are mentally hurt, and then somebody comes and asks you like random things which you can't express. Literally the most important thing that I have as a doctor has seen is people don't know how to express their pain. Can anybody express their pain? You can shout, you can cry, you can do whatever emotions you know about, but can you express the pain you have in a quantity that you have? I have 1 kg of rice, I have 2 kg of onion, and similarly like that, can you express the pain in quantity? So that is very important. Here we actually quantify the pain. In a verbal state, you actually quantify the pain. So yes, pain assessment is very important, and understanding and supporting those people who are in pain is rather more important, and taking that as a whole, be empathetic, and be try to understand what the patient is going through in every sense, and don't misjudge that the patient is just faking it, or the patient is just making to get sympathy.
Thank you, Dr. Aravind, for contributing that things, because pain assessment is very, very important, because we all already know that total pain concepts. We all focusing on physical pain, but so other aspects also we have to look into. So if they have a what we understand was what if they have a psychosocial issues or spiritual issues there, the physical distress will increase. So that is why when we do the assessment, we should do the proper assessment. So we have to assess the physical part, we have to assess the psychological part, we have to assess the social part, and also the spiritual part. So then only we will get a good picture about the patient. Okay, so when we talk about the physical part, when we do the physical pain, the assessment, we should do that fully, because now we understand what is PQRST. Is there any provocating factor or palliative factor? What is the quality of pain? The pain is radiating or not? And the severity of pain, 0 to 10 scale you can use, and temporal factors. So you are mentioned about this patient's pain is worst at night. Why? What was the factor? So we have to identify if they have why the patient pain is worsening at night, because so nobody is there, so the usually the night time they will be thinking a lot. See, if they have a psychosocial issues there, if they are not able to share, explore, so they will be thinking during the night. So that's why the pain will be worsening at night. If you do the proper assessment and explore well, definitely they can able to express their that emotions. And if you give after that, if you give some pain medications for their physical part, that will help. So otherwise it won't work fully. It will be helping partially, but it will not help fully. So you have to talk to the patient well. You have to think about the total pain concept. physical, emotional, social, and spiritual care. And also, as I mentioned last week, nurses are spending most of the time with the patients. If possible, you have to talk to the patient. Whenever the patient says pain, go and talk to them and to do the pain assessment, and then only you have to report to the doctor. So this is important. From the nurse's side, you at least you have to do the proper assessment, check whether there is any psychosocial issues there or any spiritual issues there. All things you have to assess, and then you have to report it. And one more thing I would like to highlight from this today's class is the NSAID. So whenever the doctor prescribed with an NSAID, our nurse's duty to educate the patient or proper instructions. We are the persons to give a proper instruction to the patient and the caregivers, because one NSAID can cause acute renal failure. So this is very, very important. So they have to take that if they are taking NSAID, they should take any gastric protective drugs like proton pumping inhibitor or the ranitidine or something like that they should take. And also they should take NSAID after food. And the third important thing is they should take plenty of oral fluids. So these are the three important instructions you have to given to the patient and the caregivers. The patient is on NSAID. So these are the 3 points you have to keep it in mind all the times. And also the next day you have to do the proper proper assessment. Also whether they have any side effects, that all things you should do. So I think time up, we can wind up. Any other last minute question? Any questions? If you don't have any questions, we can wind up. Dr. Aravind, do you want to add anything?
No, nothing more. You are the best in the field. What else I have to add for? Everything you need to know is, you can directly get it from Shiva sister, because the one thing you need to understand is not knowing a lot of education, knowing a lot of things. The basic thing you should have is the emotion for that patient. If you have emotion, if you know how to deal with your patient, consider half of the pain is just, being taken with your emotion and with your empathy. Don't go for sympathy, have empathy, and then you understand how much you can contribute for every patient. Even if you don't have morphine or, methadone in your hand, you can do wonders.
Yes. Okay.
I hope the class was good.
It was as an excellent session. Thank you, Dr. Aravind, for the wonderful session. Thank you, Sister Anvesha, for the patient story. Thank you all for your participation. Thank you.